Define disseminated intravascular coagulation and describe its pathogenesis. Define embolus and list the types of embolism. Describe the clinical manifestations and consequences of pulmonary and systemic thromboembolism. Discuss the clinical conditions that give rise to fat and marrow embolism, air embolism, and amniotic fluid embolism. Classify infarction. Describe the morphologic features of red and white infarct. And last, to list the factors that influence the development of an infarct. So we begin our lecture with our first objective is DIC. So remember that DIC is not a specific disease, but it is a complication of a large number of conditions which is associated with systemic activation of thrombin. As you all know, that thrombin is the principal enzyme of hemostasis, and thrombin activates the procoagulant factors and also helps in the formation of clot. It helps in the formation of thrombi. So in DIC there is multiple thrombi formation, and this widespread thrombi is present in the microcirculation. So it is also called as consumption coagulopathy because in the formation of thrombi, the coagulation factors, the clotting factors, and the platelets, both of them are consumed by this thrombi formation. So DIC is also termed as consumption coagulopathy. The causes include infections by different organisms, malignancies, like cancer cells secrete procoagulants, tissue factors, and they also secrete vascular endothelial growth factors which affect the endothelial permeability. So this is one of the cause for DIC. Then certain obstetric complications. Yes, it is an emergency. DIC is a life-threatening postmortem complication and obstetric complications. And trauma is one of the cause of DIC. So now we move towards the pathophysiology of DIC. DIC will be covered in much detail in your hematology module. So we will just have an overview of its pathophysiology in this slide. So can you see this? It's a beautiful flow diagram. Whatever the cause, massive tissue destruction or sepsis by various organisms causing infection or endothelial injury, this all causes release of tissue factor. As you know, the tissue factor is the initiator of coagulation cascade and initiates the formation of clot. So there is clot formation, and clot formation is termed as thrombus. So there is widespread microvascular thrombosis. And moreover, the endothelial injury causes platelet aggregation, and these platelets are utilized by the thrombi. So multiple thrombi are formed in the circulation which causes occlusion of the blood vessel. This occlusion of blood vessel would cause ischemic damage to the tissue the blood vessel is supplying. Then widespread microvascular thrombosis also utilizes the clotting factors and platelets. These are utilized by the formation of thrombus. So this clotting factors and platelets are very less in the circulation, that can lead to bleeding. And moreover, it can also activate plasmin. So the activation of plasmin will cause fibrinolysis, that is fibrin split products, and inhibition of thrombin, platelet aggregation, and fibrin polymerization. And activation of plasmin will also cause degradation of clotting factors. So you can see that on one hand, the clotting factors and platelets are being utilized, and on the other hand, the clotting factors are being degraded. So together all this thing leads to bleeding. So DIC is an emergency where the patient undergoes severe hemorrhage, and it can also lead to shock and death as well. So treating DIC it's very important to treat DIC promptly. And now we move towards the another topic of our lecture, that is embolism. So what is an embolus? Embolus is a detached intravascular solid, liquid or gaseous mass that is carried by the blood from its point of origin to a distant site. Like it might be solid, it might be liquid, or it might be in a gaseous state, which is detached from the point of origin. And through the blood flow, it is carried to the distant site, away from the site which has been originated. Okay, and this embolus goes and blocks the blood vessel at its end, and this causes tissue dysfunction or infarction. Then, classification of emboli. We classify them according to their consistency, which might be solid, liquid, or gas. Solid are mostly the detached thrombi or the vegetations. So, vast majority of emboli are dislodged thrombi, from the thrombus they are dislodged, or they are a part of thrombi, so also called as thromboembolism. What are vegetations? You can see in this picture, these are the heart walls. These are different heart walls, and here this yellow colored, these are the vegetations. So vegetations are the blood clots or thrombus present at the walls of the heart. So these vegetations present on the heart walls can also detach and cause embolism, right? And sometimes these vegetations are infected by different organisms like Staphylococcus aureus or Streptococcus viridans in bacterial endocarditis. So they can be infected thrombi and become the infected emboli as well. Okay. Then the solid emboli can be detached from a tumor. They can be cholesterol emboli, which can be detached from the atherosclerotic debris. They can be foreign bodies. Liquid emboli might be fat or from amniotic fluid. Gas emboli can be the nitrogen bubbles or the air emboli, which we'll discuss in our later slides. Okay. Now we also classify these emboli on the presence of infection. If microorganisms are present, we term it as septic emboli. As I told you in your last slide, that they can arise from the vegetations of heart. So these vegetations infected by different organisms in bacterial endocarditis can be the septic emboli. The microorganisms are absent, there is no infection, so they are termed as aseptic emboli. And according to the sites, if they are present in venous circulation, they are venous emboli. In the arterial circulation are the arterial emboli. Now, the types of embolism consist of pulmonary embolism, systemic thromboembolism, then fat and marrow embolism, air embolism, and amniotic fluid embolism. We will now discuss with pulmonary embolism. Before we proceed for the pathophysiology or to understand the pulmonary embolism, let us revise the normal anatomy of pulmonary circulation. This is very important to remember. As you all know, you have studied in your first year and the second year that this is the right side of the heart and this is the left side of the heart. Here the right side receives the deoxygenated blood from superior and the inferior vena cava, and then it passes through the pulmonary artery. Please remember the anatomy of this pulmonary artery, how it is bifurcating. Okay. Then this deoxygenated blood goes to both the lungs, where again the blood is oxygenated and is returned to the left side of the heart and then goes in the systemic circulation. Okay. Then pulmonary embolism occlusion is in the pulmonary arteries. So I told you to remember the anatomy, right? So the pulmonary arteries are occluded in pulmonary embolism. This is the most common and fatal form of venous thromboembolism. It is more common in hospitalized and bedridden patients because in these such patients are laying down on their bed for a longer time and there is lack of movement of their lower limbs. So this promotes the formation of clot in their lower limb veins. And this thrombus can become emboli and they can travel through the pulmonary vessels, right? And varicosities of superficial veins of the legs and the pelvic veins is another cause of pulmonary embolism. What are the varicose veins? You can see in this picture these dilated veins, right? So these are varicose veins are the dilated veins seen in the legs. In the individuals who are standing or sitting for a longer time, so these veins get dilated. And mostly they are asymptomatic, but they can become painful. And they can also lead to thrombus formation in the deeper veins, and this is termed as thrombophlebitis. And then the thrombus, when it becomes emboli and travels through the circulation, it is termed as thromboembolism, right? Then this picture shows the sources of pulmonary embolism. You can see the thrombi in the right heart, septal infarction or atrial fibrillation. Here the septal infarction can cause stasis and endocardial damage, which can create the thrombogenic surface to form thromboembolism. Then atrial fibrillation means irregular conduction of nerve impulses in the cardiac muscles, and this can lead to disturbance in myocardial contractility. So if a cardiac thrombus is present on the right side of the heart and there is atrial fibrillation, this can dislodge the thrombus and become the embolism. So another source of pulmonary embolism could be the part of the tumor, the fragment of the tumor, or any air injected in the vein, or the fat emboli, the fractures of the fracture of the bones can lead to leakage of the fat within the pelvic veins, and they can travel through the blood vessels or the venous circulation towards the pulmonary artery. And the most common ones are arising from the pelvic vein thrombi after pelvic or prosthetic surgery. And we have just discussed about the thrombi in deep veins of the lower extremities, okay? So this is the most important cause, thrombi and in deep veins of lower extremities leading to pulmonary embolism, that is deep vein thrombosis. 95% of pulmonary embolism originate from deep vein thrombosis of leg. So what is DVT? You can see these three images present here. So here you can see this is the normal vein. These are the valves present in the vein. So what is the function of these valves? That they allow the blood to flow only in one direction. The blood is moving towards the heart. Okay. So in DVT, there is formation of thrombus within the deep vein of the leg. So the immobilization is the major factor for DVT. Patients laying down on a bed for a longer time are more prone to form thrombus in the deep veins of their legs. And other causes could be hypercoagulability states or venous stasis, vessel wall injury. So this causes a damage to the valves. You can see the blood is moving in both the direction, and the blood is moving in a very slow movement of the blood. So when the blood is moving slowly, a clot is formed, obviously. A clot is formed that is called as thrombus, and this thrombus can detach from it and become an emboli. So this deep vein thrombosis, you can see present here the blood clot present in the pelvic vein, or you can see a blood clot, a thrombus present in the deep vein. It could get dislodged and they could travel through the vein to the lung, and the embolus travels through heart and gets lodged in the blood vessels of the lung. So this is how the pulmonary embolism is seen or occurs from the deep veins of the leg. Now there are special types of venous embolus as well. So please remember their name, very important. The saddle embolus and the paradoxical embolus. Saddle embolus is a large embolus impacted at the bifurcation of pulmonary artery. So you can see in this image, this is the lung parenchyma and this is the pulmonary artery and the bifurcation. So this red color you can see, this is forming a saddle shape, so termed as saddle embolus, right? And what do you mean by paradoxical embolus? The venous embolus that enters the right side of the heart and passes through, important, see, interatrial or interventricular septal defects. You have heard about them, right? So you can see this is the right side of the heart and the left side of the heart. And if an embolus is present over here on the right side of the heart and the patient is having a defect in the atrial septum, here you can see the patent foramen ovale, or the patient is having an interventricular septal defect. So this embolus from the right side could travel to the left side of the heart. So it is termed as paradoxical embolus. Okay. Now what can be the consequences of these pulmonary embolism which have been traveled through the pulmonary vasculature to the pulmonary artery? So 60 to 80% of them are silent. They do not present with any clinical symptoms as they are small. But the ones which are involving the medium-sized arteries could cause rupture, vascular rupture and pulmonary hemorrhage. As you know that lung is supplied by the pulmonary artery as well as the bronchial arterial flow. So there is lots of collaterals present. So they can cause pulmonary hemorrhage. But if the bronchial artery flow is also compromised, then it can lead to pulmonary infarction. Now another effect of pulmonary embolism could be right heart failure. When the obstruction is more than 60%, it can lead to right heart failure and it is also called as cor pulmonale. Or it can even lead to cardiovascular collapse and sudden death. Now certain emboli which can obstruct the small and arterial pulmonary branches can even cause hemorrhage or infarction. And multiple emboli coming together one by one in the pulmonary artery continuously can lead to pulmonary hypertension and right ventricular failures. So this is the summary of the effects or the consequences of pulmonary thromboembolism involving more than 60% of the pulmonary vasculature could lead to sudden death or right heart failure or acute cor pulmonale. It can lead to pulmonary infarction when both the pulmonary artery and the bronchial artery are compromised. It can lead to pulmonary hemorrhage. Then multiple emboli could lead to pulmonary hypertension, chronic cor pulmonale, or even pulmonary arteriosclerosis. Whereas majority of them are silent, they can undergo resolution. This is the picture of acute cor pulmonale. You can see again here a saddle embolus obstructing the bifurcation of pulmonary artery, and this is causing dilatation of the right heart and right heart failure, which is termed as acute cor pulmonale. Now we move towards systemic thromboembolism, where the emboli are usually present in the arterial circulation. Now the 80% of them arise from intracardiac mural thrombi. What do you understand by mural? Mural means the wall, cardiac wall. Yes. So these thrombi are present within the cardiac wall, which can become the embolus, right? So out of them, in 2/3 are associated with left ventricular wall infarct, and 1/4 of these cardiac thrombi which become embolus are associated with left atrial dilatation and fibrillation. Then they can arise from aortic aneurysm, Aneurysms are the abnormal dilatation of blood vessels. So these aneurysms can be associated with disruption of endothelium. They can cause thrombus formation and again leading to thromboembolism. Then we have talked about the cholesterol emboli, atherosclerotic plaques can become systemic thromboembolism, cause some systemic thromboembolism, valvular vegetations and paradoxical emboli we have already discussed, and 10 to 15% are of unknown origin. So, as in contrast to venous emboli, which involves the lungs, arterial thromboembolism can travel wide variety of sites like lower extremities, brain, or rarely they can involve intestine, kidneys, spleen, upper extremities as well. So the consequences of systemic thromboembolism depends on these factors. Vulnerability of affected tissue to ischemia means how much the tissue is able to, the capacity of the tissue to withstand the blood supply or decreased blood supply. Then the caliber of the occluded vessels, where the small vessels is involved, then it will occlude completely. But if the larger vessel is involved, then it can occlude partially and the flow is continued. The blood flow is not occluded completely. Then collateral blood supply, yes, presence of collateral blood supply gives the chances to supply the blood. If one vessel is obstructed, the other is there to continue the blood supply to the tissue. So there is decreased chances to develop infarction. So whatever would be the consequences, these three ones, but ultimately the final outcome of obstruction by the thromboembolism is tissue infarction. Please remember, tissue infarction. We'll see what is an infarct. Infarct is localized necrosis or ischemic necrosis of a tissue. Okay, we'll see in the subsequent slide as well. Now coming to fat embolism. Yes, so fat embolism can be found in pulmonary vasculatures. They can develop from the fractures of shafts of long bones or burns, soft tissue traumas, inflammation of fatty tissues. So, majority of them do not have clinical consequences, but minority of patients do become symptomatic. And these symptomatic patients are termed as fat embolism syndrome. So you can see that 90% of major trauma or the femur surgery, the burns, long bone fractures or total parenteral nutrition with lipoids or lipids can cause fat embolism. Entry of the fat from the bones through the blood vessels, right, into the pulmonary vasculature. But majority of them are asymptomatic. But few of them, like 2 to 5% of fat emboli becomes present with certain signs and symptoms. And these symptoms are termed as fat embolism syndrome. This syndrome develops after 12 to 36 hours after the injury, and as the pulmonary vasculature is involved, the patient presents with shortness of breath, hypoxia. Then the platelets also adhere to the fat globules. So many of the platelets are reused or they aggregate towards the fat globules, leading to decrease in the platelet count. Decrease in the platelet count is called as thrombocytopenia. So the patient can present with petechial rashes, the hemorrhagic rashes. Decreased platelets could lead to DIC. Then RBCs could aggregate the undergo hemolysis. So patient can present with anemia. Or even if the cerebral vasculature is involved, then the patient can present with altered mental status like delirium and coma. And mortality could be up to 20% in fat embolism. Okay. Now, the pathophysiology of fat embolism is based on two main hypotheses, that is mechanical and biochemical. So in the mechanical, as we understand that traumatic injury could cause fat globules to disrupt from the bone marrow or from the adipose tissue, and they are forced to travel into the torn venules in the areas of trauma, and they enter the venous circulation. Whereas biochemical hypothesis says that hormonal changes caused by trauma or sepsis induces systemic release of free fatty acids. So these free fatty acids they cause injury to the endothelium. Free fatty acid cause platelet activations and they cause free radical injury, and together they present as fat embolism syndrome. Okay. So this is the H&E picture of the bone marrow embolus in pulmonary circulation. So this, as you can see, this is the pulmonary vessel, and in the center here, this is an embolus. Here this is the hematopoietic tissue, and these are the fat globules. Okay, these vacuolated are the fat globules, and this is the organizing thrombus together with it. Then coming to air embolism, it occurs when air is introduced in venous or arterial circulation. So very important to remember that the more than 100 cc of air if present in the circulation, then only it produces the clinical effect. Okay, so these gas bubbles present in the circulation, what do? They coalesce, they join together and they form frothy masses. And this mass travels through the circulation and they again cause vascular flow obstruction and finally leading to infarction. So the venous air embolisms could arise from operations on head and neck, trauma, obstetrical complications, and intravenous infusions. Arterial air embolism could arise from cardiothoracic surgeries or even the paradoxical air emboli could occur. So next important entity to study under this heading is decompression sickness. So it is a form of gas embolism. This decompression sickness occurs in deep sea divers or scuba divers, or they can always also seen in unpressurized aircrafts who are exposed to sudden lowering of the atmospheric pressure. So you need to understand over here that when the deep sea divers, they dive under the water. So on the earth surface we have low pressures. Okay, so under the water there is high pressure. So these deep sea divers, when they breathe under high pressure, as they dive under the water, they are under high pressure. So what happens under high pressure? Their blood gases like oxygen, carbon dioxide, and specifically the nitrogen to be remembered over here, it dissolves in their blood. Okay, at high pressure, under high pressure in the water. Now these scuba divers are instructed to come on the surface where there is low pressure very slowly. They should ascend very slowly from the water to above the sea. But if they ascend quickly, what will happen? If they ascend quickly from under high pressure to the low atmospheric pressure above, these dissolved gases, especially the nitrogen, they become undissolved and they form small bubbles within the circulation. Okay, so the deep sea divers who are under high pressure under the water, if they arise quickly on the low atmosphere upwards, these gases becomes undissolved and they form small bubbles within the circulation. Now this undissolved bubbles like oxygen, carbon dioxide again redissolve, but nitrogen, remember, nitrogen is less soluble and it persists in the as small bubbles in the blood. It passes in the circulation, right? And this is one form of air embolism or the gas embolism, you can say. So these bubbles are trapped in the circulation and leading to hypoxic injury of the tissue. So you can see when our surrounding pressure increases or decreases, the amount of nitrogen our body can absorb changes. So this deep sea diver is there in the water. The surrounding pressure increases and nitrogen travels under high pressure from the lungs to the blood. Okay? Now this diver ascends too quickly above the sea. Okay? So here what will happen? It will not allow ascending too quickly, won't allow enough time for the nitrogen to leave the blood and resulting in bends. I'll explain you what is bends. But at this moment, just remember, try to understand how the nitrogen bubbles are formed. If the scuba diver does not ascend slowly, if it ascends very quickly, then the nitrogen in the blood remains undissolved. It forms small bubbles within the blood, and these bubbles are circulated as gas emboli within the vasculature. Okay, now we come here to study the three entities, that is bends, chokes, and Kazan disease. Please remember, bends is the rapid formation of gas bubbles within skeletal muscles. These gas bubbles deposit in the skeletal muscles, in the supporting tissues and joints, and lead to painful condition that is termed as bends. If these gas bubbles are within the lungs or the pulmonary vasculature, could cause edema, hemorrhage, and respiratory distress termed as choke. And one more term to remember is Kazan disease. Kazan disease is a chronic form of decompression sickness. So Kazan is a French word, you can see these are the Kazans. These are watertight retaining structures which are used for bridge constructions. And the workers in these pressurized vessels are there for a longer time. So such patients suffer from acute or chronic decompression sickness termed as Kazan disease. So the signs and symptoms of decompression sickness depends on the site the nitrogen bubbles are deposited. If they are deposited within the knees, elbows and shoulders, they cause joint pain, they can cause tingling, pins and needle sensation, they can cause skin rash, or even vertigo, poor balance, confusion, nausea, fatigue or unconsciousness. So do not delay the treatment. The treatment should be given very promptly. So here you can see the hyperbaric chamber where the patient is kept under it, and under sufficiently high pressure, you have to force the gas bubbles back into the solution. And then subsequently the slow decompression is done. Now next is the amniotic fluid embolism. This is the fifth most common cause of maternal mortality worldwide. The cause is complication of labor and immediate postpartum period where there is a tear in the placental membranes or ruptured uterine veins, okay? And the amniotic fluid or the fetal tissue is infused in the maternal circulation. So here we have the biochemical activation of these clotting factors, the coagulation factors by the amniotic fluid, the amniotic components, and the mother presents with dyspnea, cyanosis, shock, neurological impairment, pulmonary edema, and DIC. So at autopsy, if in case the mother does not survive, so what we see in autopsy that fetal skin, lanugo hairs, squamous cells are shed from the skin, fetal skin, and fat from vernix caseosa are present in maternal pulmonary circulation. So here you can see this is the pulmonary vessel, and in the center these whorled are the fetal squamous cells, and rest of the tissue is showing edema, and this red are the blood vessels showing hemorrhage. That was all with the embolism, where in the starting we just had an overview of DIC. Then we studied what is embolus, the types of embolus, the types of embolism. Now we move towards the next topic of our lecture, that is infarction. So infarct is an area of ischemic necrosis, yes, caused by occlusion of either arterial supply or venous drainage. Okay. So the examples include myocardial infarction, cerebral infarction, pulmonary infarction, bowel infarction, and also the ischemic necrosis of extremities leading to gangrene, most common in diabetic patients. Okay. Now the causes of infarction could be thrombotic or embolic arterial occlusion. A thrombus can occlude the blood vessel, or an embolus could occlude the blood vessel and cause infarction or ischemic injury to the tissue which is being supplied by that blood vessel. Or infarction could be caused by local vasospasm. You can see in angina. Angina, here the coronary blood vessel, where there is local vasospasm, the narrowing of the blood vessel for a shorter period of time could decrease the blood supply to the myocardium. Or hemorrhage into the atherosclerotic plaque, or the cholesterol emboli from the blood vessel could go and lodge in the coronary artery, or there can be extrinsic compression of the blood vessel by a tumor, torsion of vessels. You can see this is the normal testis and the spermatic cord. Here the spermatic cord has undergone torsion, twisted on itself, and the blood supply by the testicular blood vessels is hampered, and the testis has undergone infarction. Then there could be traumatic vessel rupture. Anterior compartment syndrome means there is vascular compromise by edema. You can see you have studied the compartments present in the calf muscle, yes, in anatomy. So any swollen muscle could compress the blood vessels and nerves in the leg and lead to infarction of the tissue supplied by them. Again, the infarcts are classified according to the color. They can be red, white, according to presence or absence of infection. They could be septic, or without infection could be bland. According to the duration of infarction, they could be early or fresh, which are usually red and hemorrhagic, whereas late and old infarct are white and compressed. Now coming to the red infarction, here we have these red infarcts are usually by the venous occlusions, for example, testicular torsions. Then they are seen in loose spongy tissues. Very important to remember, for example, lung. So what does this, that the lung is a loose tissue. So it allows the seepage of blood, the movement of blood from the adjoining capillary beds, right? So it appears red and hemorrhagic in loose spongy tissues. There is hemorrhage, and the RBCs are leaked out the surrounding loose tissue, so it appears red. Then red infarcts are seen in organs which have dual circulation, like lung and small intestine. They are seen in tissues which are previously congested by sluggish venous outflow. Red infarcts are also seen when the flow is re-established to a site of previous arterial occlusion and necrosis. For example, following angioplasty of an arterial obstruction. You know what is angioplasty? It is the repair of the coronary vessel where the clot is formed. Okay. So in this, again, the myocardium has been supplied by the blood, the re-establishment of the arterial circulation. So here it can cause red infarct. Red infarct here, if you remember your chapter 2 where you have studied your reperfusion injury, yes? So this is one of the example of reperfusion injury where there is oxidative stress, increased calcium overload and inflammation, and this is causing more injury to the tissue, and this injury could lead to red infarcts. Here is the picture of the lung here, and this is the red hemorrhagic infarct seen over here. This is the picture of intestine. These are the normal intestinal folds, press intestine here, and this loop of intestine is red and showing red hemorrhagic infarct. Then we'll talk about the white infarcts. These are usually seen by arterial occlusion, commonly seen in solid organs which have end arterial circulation, right? So certain solid organs like heart, spleen and kidney present with white infarcts. Here the tissue is solid. So the blood does not leak or in the adjoining capillaries. There is very little hemorrhage. So they appear white. And they are, most importantly, remember, they are wedge shaped. So this is the section of the kidney, and here you can see this is the wedge shaped infarct, and the apex denotes the occluded blood vessel. There could be the blood vessel over here, and this apex of the wedge is showing the occluded blood vessel, and the base of the infarct is formed by the serosal surface. And this is another example of myocardial infarction. This is cut surface of the heart. You can see this is showing infarction, white infarct, and this is the coagulative type of necrosis seen here in the solid organs. Again, this is the lung parenchyma, and here this is the red hemorrhagic infarct in the lung, which is roughly wedge shaped. But when you compare with the white infarcts seen in the spleen, this is the sharply demarcated seen in spleen. These are the cut sections of the brain. You can see these are the punctured hemorrhages. This is showing edema, localized edema. You can see the ventricle here has become narrowed. This is due to presence of edema in this part of the brain. Again, here are the punctured hemorrhages present. And finally, necrosis seen here in the brain is liquefactive type. Okay, then we have the septic vegetations on heart walls. We have discussed a lot about the vegetations. This is the cut section of the heart. These are the walls present, and you can see this red color. These are red vegetations. It could be infected by the organisms. This can cause septic emboli, which can cause septic infarction, and again can lead to abscess formation at the site of infarction. So the pathogenesis of infarction says that first initially there is local hyperemia, then this affected part becomes edematous and hemorrhagic. There are certain reversible cell injury changes seen in the cells. Then progressively there is a proteolysis of necrotic tissues and RBCs. Further, the blood pigments are released by hemolysis. The RBCs undergo hemolysis. The blood pigments, the hemosiderin pigments are engulfed by the macrophages. Finally, there is inflammation, acute and the chronic type, and there is growth of granulation tissue. And after few weeks or months, the infarct is replaced by fibrous tissue. So this is the image of the kidney. This is the parenchymal surface of the kidney. You can see this is the demarcated area. This is red in color. You can see the contrast. This is the yellow, or you can see the paler area seen over here. So this is a long time after the infarct. This area is showing fibrosis. So the white infarcts are the arterial insufficiency, not reperfused, single blood supply, whereas red infarcts show venous insufficiency. They can be reperfused by the dual blood supply. So this shows the difference between the red and the white infarcts. Red infarcts are caused by artery or vein occlusion or reperfusion, whereas pale infarct are caused by arterial occlusion. Red infarct are observed in soft organs having loose tissue, remember, that is brain, liver and GIT, whereas pale infarcts are usually seen in solid organs, that is heart, kidney and spleen. Red infarcts are typically includes dual blood circulation, whereas pale infarct includes single blood supply. Red infarcts have the loose texture tissue allows RBCs released from damaged cells that will flood the necrotic tissue and infarct will appear red, whereas in pale infarcts, these are referred to as white because there is lack of hemorrhaging and limited RBCs. Do remember these differences? And this picture shows the infarcts of different organs with their gross appearance and the outcome. You can see the pulmonary infarction and the intestinal infarction are hemorrhagic, whereas rest of them appear pale on gross appearance. The myocardial infarction and intestinal infarction are frequently lethal as compared to other organs. Okay. So the last part of this lecture is about the factors that influence development of infarction, that is anatomy of the vascular supply. So you know that the certain organs like lungs, liver, which have dual supply, like lung is having pulmonary artery and bronchial arterial supply, liver with hepatic artery and the portal vein. So these organs have relatively resistant to infarction, whereas in contrast to the solid organs or the tissues which have an arterial supply, like kidney and spleen, they are more prone for infarction. Then second depends on the rate of occlusion. Obviously, the slow developing infarct are less likely to cause infarction because they provide time to develop collaterals. And then the tissue vulnerability to hypoxia means, certain tissues, for example, we can say about neurons. Like these neurons, if there is decreased blood supply to the neurons, they hardly take only 3 to 4 minutes to develop irreversible damage. Okay, whereas when we compare with the myocardial cells, if the blood supply is hampered to these cells, they die after 20 to 30 minutes. But when we talk about fibroblasts, they are pretty hardier than the myocardial cells. They remain viable after the blood supply for many hours. So it depends upon the tissue affected. And lastly, the hypoxemia. Obviously, any abnormally decreased oxygen supply could lead to high rate of infarction. So in the end, we'll cover the key points quickly. An embolus is a solid liquid or gaseous mass carried to a distant site from its origin. Types include pulmonary embolism, systemic thromboembolism, fat, air, and amniotic fluid embolism. Infarct is an area of ischemic necrosis caused by occlusion of either arterial supply or venous drainage. Then infarcts are red or white, or they can be bland or septic. That's all for this lecture. If you have any queries, you're welcome to ask. Thank you and take care.